Hi, welcome to this week's episode of JAMA Network Open Live. I'm Seth Truger, Digital Media Editor for JAMA Network Open.
And I'm Mike Berkowitz, Electronic Editor for JAMA and the JAMA Network.
Great. Of course, if you're following on live, please feel free to comment, send in questions, concerns, funny comments. Not pictures of your bruises, Min, but but you can either comment below in Facebook or YouTube, or you can @ us on Twitter at JAMA Network Open and tag with JNO Live.
And if you're watching this after the live broadcast, you can leave comments and questions in any of those platforms, and we'll follow up with you on Facebook, YouTube, or Twitter.
Great, thanks. So first article we've got, this one I really liked, is Assessment of Employee Susceptibility to Phishing Attacks at U.S. Healthcare Institutions by Will Gordon and colleagues.
Phishing attack. So to define that for the audience, you guys may know, but it's the attempt to kind of get your information by sending people a link in an email, typically, and you click it and it kind of gives the sender access to your account, your passwords, and other kinds of personal information. It's a kind of cyber, not warfare, but a cyber attack.
Yeah. Right. Yeah. So what's really interesting is that a lot of healthcare institutions, hospitals basically, have been doing their own simulated phishing attacks or hiring contractors to do simulated phishing attacks, basically as a way to make sure their employees aren't clicking on them, to test them, to see, are you doing it? Do you know? Are you aware of clicking? Is just basically it's a way to both train up the workforce to be compliant and also identify weaknesses in the system.
Right, but I think the reason for that, Seth, is, and this is kind of off the record because somebody told me this and I can't give you a kind of a source, but hospitals and academic medical centers are targets of these attacks. And I believe there have been some substantial payouts in kind of ransomware attacks. So basically, it's really just a money play where these bad actors are targeting institutions and say, give us $12 million and we will not release, or maybe even more, billions or something like that, and we won't release all the private data of your patients.
Yep.
So it's a real security issue that we as kind of practitioners aren't so aware of because we're not cybersecurity experts. But it's an issue that U.S. and international players are facing.
Right, exactly. And given the amount of clinical patient data we have at hospitals, it's relevant both, to make sure that we have access to it so we can take care of our patients, make sure that our systems are up and running. That can all be held ransom. And also, I imagine it would just be very embarrassing for a big institution to have this, and there'd be a big motivation for basically blackmail here.
Right. And so one of the things that you pointed out to me about today's study that I didn't pick up on the first time I read it is that this was kind of a QI effort on the part of these medical centers. Yep. These are medical centers sending simulated phishing emails to their employees to test. You may have said that already, but I kind of wanted to make that clear.
Right, sure. So let's get into the study. They looked at 6 different hospitals. They anonymized them, which is nice of them, and particularly relevant. They looked at 95 different simulated phishing campaigns, which was almost 3 million emails, with an overall average click rate of 14.2%. So about 1 in 7 employees who got an email clicked on it.
Got it.
1 in 7 emails got clicked on,
right.
Of those 3 million.
That's where the buzzer goes off.
Right.
Not supposed to do that, right?
Yep. And there was a lot of variation at the different institutions. Different healthcare institutions had different rates of clicking, which who knows what that means. That could be all sorts of variation or just random noise.
Okay. So healthcare employees are prone to do this. I mean, not at a high rate, but at a substantial kind of proportion. But did they tell us anything? We physicians or clinicians or providers like to think maybe that we're educated and smart. Do we know how the actual clinicians responded in comparison to other hospital staff?
I didn't see that. I know they had, they did, that's actually a good point that you bring up though, is that they didn't just look at the clinicians, they didn't just look at the doctors and nurses, they looked at all the healthcare employees.
Right.
And I don't know, did you see that answer there?
I didn't. I don't think they report it.
I don't think they did.
But just to be clear about this study, I think, and not to cast aspersions, but I'm going to kind of randomly come up. These are x-ray techs and orderlies and everybody, I think, who has an email account within the system.
Even people who work in IT.
Even people who work in IT. So what were the kind of finer nuances here? Were there kind of particular types of phishing things that were more people were more prone to click on?
Yep. So they divided it into 3 different categories. So office-related, personal, or IT-related. And not surprisingly, the IT-related emails were clicked on the least. Probably less because we didn't get fooled as easily, but more because I don't care as much if I get an email from IT.
Right.
So things like your mailbox has exceeded the storage limit, or updating your database, The office-related things were things like you have received a new fax, you're expected to review this document, here's this online workplace safety training module you need to click on. So these are things where it would certainly make sense to me if clinicians were clicking on these office-related things more. The highest rate was actually the personal things, so things like your new credit card's here, someone sent you a Halloween e-card, and we are pleased.
You're not supposed to be getting those at your work email inboxes, by the way.
And we're pleased to announce that you're eligible to receive double rewards, is another example they gave.
Okay.
And those rates were higher. The odds ratios were 1.4, 1.5.
So you may know this from all of your kind of local institutional education, but the kind of there are things that kind of betray a phishing as opposed to a legitimate email. The design's bad. There are slight errors in grammar. There are some misspellings. If you look at where it's coming from, it's often a familiar kind of URL-like email that is like a website address-like email. But there's something off. It's a kind of a variation of what's real.
Right, and oftentimes there'll be things where like they change, they use an L instead of a 1 in a link or something like that, or letters, two letters that smush together look like another letter but aren't actually that letter. But some of the real attacks can actually be pretty sophisticated. In fact, one of my complaints about my institution's test phishing emails that I primarily use the webmail, not actual Outlook, and don't get me started on Outlook webmail, but the way the internal security masks the URL to go through virus checks and things like that, you actually can't tell what the URL is you're clicking on. You can't really tell if you're clicking on it. That being said, the punishment for doing it wrong is literally to look at a one-slide little module, so it's not that terrible, but I still feel bad. It's still, that embarrassment.
So that's your institution's way of doing this study, which is kind of testing you and saying, you shouldn't have clicked.
And actually, the two institutions I've been at that have had these test phishing cases have both been really good, where basically, instead of saying everybody do this module on phishing and IT security, it's just the people who click on the links who have to do it. So I was very happy the first time I got one of these. It was at my previous job. And it was during the presidential campaign in the summer. They sent out a fake CNN update that Donald Trump had dropped out of the presidential race. And I was like, wait, what? And I was about to click on it. And I was like, wait, no, I should Google this. And then my wife, who's also in healthcare, clicked on it.
Oh, is that right? Go to Snopes.com. I don't know whether you know that website, but that always debunks or tells you whether these kind of internet memes or internet stories are true or false.
Yep, or just Google it first. It's the same kind of thing if you get credit card links or stuff like that. Obviously, tweets are not, or JNO live streams are not, IT advice. But
Right. So I'm going to pivot for a second and kind of just bring up one other aspect of this, which is not strictly speaking phishing, but I don't know about you, but I get emails all the time from quote-unquote predatory journals that are trying to get me to click a link and submit my manuscripts at their journals. Do you get those?
I get those all the time. More and more of them are going to spam automatically, though, which is nice.
Okay, because I just heard a story of a young investigator, somebody who was starting in their career, who responded to one of these, and I think as a kind of a process of inquiry, submitted her manuscript, and they snapped it up and started kind of sending her threatening emails asking for both money or that they were going to kind of report her or something of that sort. And then she had her manuscript, which is a legitimate academic effort, trapped and online, basically, published, which jeopardized her chance to get it published in a subsequent legitimate journal. So it's not phishing per se, but there are bad actors who communicate by email who are trying to get things from us as researchers, as clinicians. And I just kind of want to put that out as a kind of related word of warning to any medical students or young investigators or young academics who are watching us. Watch out for predatory journals. And there is a directory of open access journals, and the reason open access comes into this is because most of these predatory journals kind of bill themselves and market themselves as open access, meaning that they'll just put it up online and it'll be free for anybody. Now that aspect is true in the sense that it's free, but it's also theft.
Right. Because basically what they're trying to do is get the authors to pay the fees.
Right. So the DOAJ.org is the directory of open access journals. And if you're interested in having your work published in an open access forum, check there first to make sure the journal's legitimate.
Right. And that's DOAJ, D-O apple juice, not D-O-H-A, which is how I always hear it.
Which is also, I believe, the capital of Qatar, Doha.
Yeah. Right? I just know there's some sort of big business world meeting there a couple
Yes.
of years ago. That's all I know about it.
Okay.
One last interesting thing I found in this paper is there was no change over time, just with the natural progression of time. The employees at these hospitals were not getting any better at recognizing these phishing emails. But the hospitals that had more phish testing campaigns, the employees did better over time. And actually decreased a fair amount. After 10 campaigns, the odds ratio was about 0.3. So basically, you know, your bosses are going to be doing this more. Your hospitals are going to be doing it.
Right.
It's probably good training. It's probably reasonable. I would suspect that if you open up the time window more, as like, you know, probably on the order of 5 to 10 years to decades, we'll all get better at not clicking on phishing emails.
Right.
Because it's not just at work that this happens.
I didn't find that finding surprising. Kind of the more that they harangue you,
Right.
the more you're like, I'm not going to even open. I'm just going to delete that. That didn't seem particularly surprising.
No,
to
but
me.
I was surprised that there wasn't a natural improvement over time.
That there wasn't an improvement.
Yeah, over time. That time itself wasn't that it had to be the email campaigns, not just each year the rates were about the same. It was only with more campaigns. And I would expect that as more of these kind of identity theft type things have become more and more of our daily life all the time, we'd all get better at it, but apparently we don't.
Okay.
Or they didn't find that in this study.
So hug your institutional IT cybersecurity expert today.
Right, absolutely. All right, should we move on to the next one?
Yeah. What do you have next?
All right, next is race and ethnicity and geographic access to urban trauma care from Elizabeth Tung and colleagues.
So I personally love this paper, which I don't usually come out on live broadcast and saying, I thought this was fabulous. Tell the viewers what it showed.
Right, so these were researchers from the University of Chicago, which is about almost 2 years ago, became a level 1 trauma center for adults again, after a pretty big controversy for a number of years.
Right. We're going to talk about that a little bit, but
great.
Yes.
And they basically looked at Chicago, LA, and New York City and tried to see if there were differences in where trauma deserts were by race and income. So are there areas that are more than 5 miles or 8 kilometers, because you have to be metric, I guess,
right.
Where there isn't access to a trauma center? They did some other fancy things looking at income, they didn't directly look at things like transport times because it's 1, harder to calculate, and 2, harder to standardize because the amount of traffic going 5 miles in Chicago at 3 in the morning versus 3 in the afternoon is very different. But they did some interesting stuff to look at. And there are some really fantastic maps in Figure 2.
Right. So, you know, I've heard in kind of the popular press about food deserts, which are kind of neighborhoods, vast tracts, generally in urban settings where they're in lower socioeconomic census tracts or neighborhoods where there's really not good access to healthy foods. Forget organic, but just produce that feeds a lot of the cardiovascular risk factors because the only access to food that they have is low nutrition and high fat and so on, and inexpensive. But this is the notion of trauma deserts. It's the same idea, just that if you are in a car crash or, God forbid, shot and injured in a way that is near lethal, you don't have easy access to a trauma center that can provide you comprehensive care, which you would presume would improve your chances of surviving that injury.
Right. And what's really interesting is a lot of the research on this kind of regional variation is usually urban versus rural splits. And rural areas, there's big questions because basically fewer people spread out over a big area.
Right.
And questions about should there be helicopter-based EMS systems or how do you regionalize trauma care?
Right.
That's been studied well, partially because of the way we fund and or overfund rural research.
Right. Got it. And so this study included trauma level 1 and 2 centers in their definitions of trauma deserts.
Right.
Can you remind viewers what the difference is between a 1 and a 2 and a 3?
I don't know exactly the differences all the time. I know the main difference between 1 and 2 is whether there's research going on. You need to have specific research support at level 1. And I believe everything has to actually be in-house at a level 1 trauma center. And with level 2s, it can be a reasonable amount of time away. Like the surgical specialist can be, I think, is it 20 minutes or half an hour away?
Something like that. So I printed out something from the American Trauma Center, and there's lots and lots of lists there explaining the difference. But elements of a level 1 trauma center include 24-hour in-house coverage by surgeons and prompt availability of care in multiple specialties, basically everything that you would think at a major academic medical center. And a level 2 trauma center is able to initiate definitive care for all injured patients. So the idea is that their resources may not be so deep that they can see people through critical illness. It has 24-hour immediate coverage by general surgeons, other folks, but they may not be in-house all the time.
Yeah, exactly. Yeah, I think the way I generally think about it is the natural split is between 1 and 2 and 3 and lower. I'm a snob. I work at a level 1 trauma center.
Right.
Take that bias for what it is.
Right.
The main difference between 1 and 2 is 1 and 2 both have the general or trauma surgeons in-house, the emergency docs, the anesthesiologists, but the specialty surgeons may not be immediately there, but are very quickly available. Although in a lot of big training centers, you can still get specialty surgeons in quickly. The different level 3 trauma centers are basically able to stabilize and send you to a level 1 or 2.
And if any of you watching have experience with this, if you guys are trauma surgeons or people involved in trauma care, send us a comment and we'll try and incorporate your perspectives into this conversation. Sure. So what did this show?
Yeah, so it showed that, not surprisingly, there are trauma deserts.
Yes, they exist.
They exist. There are, again, if you look at the maps in Figure 2, there's basically areas of access to over-access trauma centers, which largely has to do with income, or where people, basically where white people live and where higher incomes are. And that New York, Chicago, and LA, the 3 biggest cities in America by population, have very different splits in how this goes, which makes a lot of sense because the densities are so different. I looked up some basic stats. So New York City proper has 8.6 million people in 300 square miles of area. LA is 10 million people in 500 square miles, and Chicago is 3 million people in 234 square miles.
Okay.
So those densities are all over the map, and they're just very different places. And having lived in Chicago and New York, they're just very different cities.
Right. So I would imagine then that the findings are that there's not as many or as much trauma desertness in New York City,
right,
because it's denser and everyone's closer to one another and to these centers.
Right.
There's more in LA, and there would be in between in Chicago.
Yep.
But is that true?
That's pretty much how it bore out.
Okay.
And what was a little interesting too was when you look at income as well, and if you look at Figure 1, that shows these really interesting scatter plots with both race and access to a trauma center plotted against income, and that LA had low access clusters in 6 of the 9 wealthiest census tracts. And I have to admit, I'm a Yankee. I grew up on the East Coast. I live in Chicago. I've been to LA only a handful of times. I'm mostly ignorant of LA.
Yeah.
But that certainly sounds pretty interesting, especially with how big LA is.
Got it. And just to be clear, if I read this correctly, the authors of this study are primarily from University of Chicago. You mentioned that earlier, but University of Chicago has been kind of the poster medical center for this issue. Because they're located on the south side of Chicago, very near to these census tracts that are disadvantaged, relatively speaking. And for years and years and years, they did not have any substantial, I think, emergency medicine program and trauma center. You can correct me on the first.
The emergency medicine program has been there for a long time. It's, I believe, the second, I might be getting it wrong, but second oldest emergency medicine residency. It's been there since the early 70s. It's one of the top tier EM residency programs, great emergency department. But I believe it was in the mid-'80s they stopped being a level 1 trauma center for adults.
Got it.
Which basically, it's one of those things where it's a tricky question because it takes a lot of resources to be a level 1 trauma center. It is really expensive. You need to pay a lot of docs to be there, pay a lot of docs to be on call. You have to recruit docs who are willing to be on call all the time, which I work at our community affiliate a bit. It's tough. We have a lot of issues. We're a pretty good place in a pretty nice area, and it's still pretty hard to get all the specialists just for a regular call.
Right. So this is I'm going to kind of follow through on that.
Sure.
This is inevitably a question of money,
right,
particularly in these disadvantaged neighborhoods where you have non-paying kind of patients who happen to be near lethally seriously injured. Let me put it that way. And that was allegedly why the University Medical Center on the south side of Chicago resisted for a long period of time community urging to open up a trauma center because they just saw it as a cost center. It was going to be a huge investment and a huge loss center for the medical center.
Yep.
But as you mentioned, in May of 2018, they opened up level 1 trauma center.
Yep.
And I don't know what the word is on the street with regards to what the experience is, but these authors actually did an analysis and report that the opening of the medical center in May 2018 attenuated the racial disparities to trauma access care in Chicago for the African American community by a substantial amount. And if you look at their E-Table 2, they show persistent disparities, an odds ratio adjusted for poverty of about 1.85, but that's much less than they report in this study, which took place in 2015.
Yep.
So that's kind of a happy message. And to me, that's really kind of the more interesting aspect of this. It's not the primary analysis and it's not the primary study, but this kind of natural experiment of how racial disparities change when you introduce one of these level 1 centers into a trauma desert. It was really, really intriguing to me, and I think probably deserves further, more long-term study.
Yep, absolutely. Yeah, it's really interesting stuff. It's also, you know, cities are big. Like I said, there are hundreds of square miles, and most cities only have a handful of trauma centers. So where they are, how many they are, whether one loses or gains trauma status makes a big difference. In Chicago, I looked it up. I mean, I could probably be forced to get this if I needed to under duress, but there's 5 level 1 trauma centers for adults in Chicago.
Yep.
I did my residency in New York, and there's only 3 in Manhattan. And it's also always a little complicated because New York used to not use the American College of Surgery Trauma Center designation. I think they do now.
Okay.
But yeah, this stuff varies quite a bit, and if one place comes or goes, it changes things a lot. Which is why things like community advocacy can make a big difference.
Got it. So I'd be interested in a study looking at this nationally, kind of just defining where the trauma deserts are, just as a baseline to understand where the care needs to be. And my props to the University of Chicago authors who did the study.
Right, and also the University of Chicago for being a level 1 trauma center.
Awesome.
It's a hard decision to make. It's not easy math to make it work.
Right, and the chair or the chief of that department, Selwyn Rogers, is actually one of the authors on this piece.
Yep, he's the chief of trauma surgery who was brought on to become a level 1 trauma center, which unfortunately happened after I left being faculty there.
So somebody I know calls these happy papers, and we love happy papers because they give good news.
Right, and now there's a paper where I don't really know what to make of it.
Okay, yeah.
All right.
Well, maybe you do. So if you, after you listen to his description, leave comments, and we will kind of incorporate that into the conversation if we can, if you understand what this paper means.
Right. All right. So this is assessment of risk of harm associated with intensive blood pressure management among patients with hypertension who smoke, a secondary analysis of the systolic blood pressure intervention trial by Joseph Scarpa and colleagues.
Right. And you may know that better as the SPRINT trial. That made huge waves in 2016, I believe. Which showed that intensive blood pressure lowering led to improved cardiovascular outcomes compared to kind of standard blood pressure lowering.
Yep, and that study, if I remember correctly, was the one that made big headlines because they stopped it early for benefit or made a big press conference before it had been peer-reviewed and published because they thought their findings were so robust that the world needed to get the information before it went through the process.
Well, I know at least the second point is true, and I forget, not sure whether it was stopped early, but they announced the findings early to the press before the scientific and clinical community had a chance to evaluate and decide how to react clinically to it.
Yeah, sorry, I'm probably wrong on that.
Anyways, so JEMMA's published a lot of secondary analyses. We published Sprint Mind, which looked at the effect of blood pressure lowering, these 2 different strategies on dementia and mild cognitive impairment. There have been other sub-studies. This is yet another sub-study. And so what are they looking at?
So basically, they looked at the 9,361 participants in SPRINT and then did a random forest-based analysis, which is a type of machine learning where you keep doing branch points and dividing the patients into different clinical categories, and basically use machine learning to try to find a heterogeneity of treatment effect, or basically subgroups who do substantially better or worse than the main analysis does, to try to see, are there different subgroups who, say, in this case, do better with higher blood pressures.
Got it. So forest analysis makes me think that it's easy to get lost in the forest with this kind of analysis, which I think is true. It's a little bit of a black box because we're moving to a point where machine algorithms and machine learning actually does the work because it learns it's running through the data multiple times, kind of where the best fits are for the data, and then spits it out, and we as investigators kind of take the algorithm at their word. That scares me a little bit. I'm not sure I completely understand it. but the machines are getting smarter than we are using our Stata or whatever other statistical programs we're using.
Right. It's as you say, to put some numbers behind that, there were 1,000 trees tested in the random forest, and they had 5,250 leaves in the trees. And in the majority, they say like in the majority of leaves, the SME association was the same, that there weren't subgroup differences from the main groups. But basically what they found is that patients who smoked, who started out with a systolic blood pressure of 144 millimeters of mercury or higher, actually did worse when you aggressively brought their chronic blood pressure down.
Right. And so that's counterintuitive, because you would think that they have higher cardiovascular risk by virtue of their smoking habit, and they would be ones you'd want to be more aggressive on.
Right.
So I don't know what to make clinically of that finding, or whether it's an artifact of this statistical analytical approach.
Right. So I think, the phrase explanatory hypothesis generating secondary analysis is repeated a number of times here. This hypothesis generating, this is a post hoc subgroup analysis. And it's very, very possible that this is just statistical noise. I'm generally a skeptic at heart with subgroup analyses in particular. So I would want to see much better data before making any recommendations to anybody about this. There's also a lot of methodology on machine learning, which they do, which seems very rigorous on how to make sure it's not a type 1 error or a false positive finding, but it also, 10,000 people look at 5,000 leaves. Something's going to be a little different, and there's a big chance that it's some noise.
Right. Okay, so that's the author's way of saying, not ready for prime time, don't believe these results, or at least don't bring them into your practice until, with this kind of signal, we can test in more traditional ways whether we should be treating hypertensive patients who smoke differently with respect to sprint trial findings.
Right, absolutely.
There was a little bit of a dust-up over this study on Twitter over the weekend, initiated by a tweet by Bobak, if I have pronounced his name correctly, Zianian. Forgive me if I've mispronounced your name. Anyways, he launched a conversation by posting a tweet about this, by tweeting a tweet about this, that said, well, what's the nature of subgroup analyses? Are we at this, because subgroup analyses, if you don't know, they are hypothesis generating, but studies aren't designed to kind of tease out effects in any definitive way for these small groups of patients, however you define them. In clinical trials or in observational studies, you basically design studies to find a single effect or test an estimate of association. And if we are at a stage now where we are kind of spinning out subgroup analyses to find which subgroup analysis might be productive, that may be, this tweet thread seemed to suggest, running in the wrong direction, and especially then to slap a brand label like Sprint on it, and possibly to slap a brand label like JAMA and JAMA Network Open on it, may be going in a direction we may ultimately regret, I think was the sentiment of this Twitter thread over the weekend.
Yeah. And that's certainly something to be cautious about. One of the big questions is there a file drawer problem, basically? Did they look at this with a million different other things and say, oh, what about people who, not smoke but don't exercise enough?
Right, not reporting your negative results are the ones that seem less interesting.
Right, and one thing of note that stands out to me is there are 9,361 participants in Sprint who are part of this random forest analysis, but only 466 participants who are current smokers with systolic blood pressure greater than 144, which they even admit is basically, that's where the data said it's a continuous variable. There's nothing clinically relevant about a blood pressure of 144 versus 143 or 147.
Right.
This is, essentially what, potentially could be data dredging.
Right. And only about 10% of these patients in the Sprint trial, 10 to 15% were smokers. About 40% were former smokers. So I'm not quite sure what to make of it. It actually applies to a pretty small group of patients in this trial.
Right.
And forest analysis, I'm going to make a bad joke. Forest analysis, I think, is a version of what's called classification and regression trees, or CART. As a form of analysis on anabolic steroids. And this is a version of CART, and it's putting the cart before the horse in this respect, because it's kind of the statistical tail wagging the clinical dog. That is to say, as we suggested earlier, this is a statistical finding. We don't know if it's clinically meaningful at all.
Right, and I'm very happy to be proved wrong here. If there's a good prospective RCT or other sort of prospective trial that can show that this group does do better without intensive control. I mean, I'll be honest, my first response when I heard about Sprint was like, there's, there's potential for a lot of harm with intensive blood pressure management,
Right.
especially with the hullabaloo it got with the press early on before publication and peer review. Certainly made me critical in that direction. So I admit that I'm being skeptical in every direction here.
Right.
So, generally things that, sound good to be true end up being too good to be true.
Right. Work with your patients, figure out with them what they want, with your advice for what they should do, and come to an agreement, and then do that.
Right. So that's it for the 3 papers we're going to talk about in depth today. Going to run through a little bit more from the last release from this past week. Of course, these are all available. They're open access, free online at JAMAnetworkopen.com. There's the Association of Leisure Time Physical Activity across adult life with all-cause and cause-specific mortality. In some ways, as many commenters on Twitter put, this is of course, people who are physically active in their leisure time, and of course, people who have leisure time to be physically active are probably more likely to have lower mortalities, and they are. What was really interesting here is that they found that people who became physically active later in life got most of the benefit from physical activity. So the point isn't that you don't have to exercise now, you can exercise later and be fine. The point is that it's never too late to start.
Got it. And so it's not watch Netflix, it's watch Netflix while you're spinning.
Right, exactly.
Okay.
Some other things in this release that I found interesting, the Association of Criminal Statutes for Opioid Use Disorder with Prevalence and Treatment Among Pregnant Women with Insurance in the U.S. So basically, states where there are laws that says it's basically punish pregnant women for opioid use disorder have lower rates of diagnosis, which probably has, and lower rates of treatment, which probably has basically a deterrence effect of criminalization of drug use in pregnancy as a deterrent from getting appropriate treatment.
Got it. And can I get, if I'm pregnant, can I get buprenorphine naloxone safely for my baby?
I think there are treatments you can get.
Okay.
I don't want to.
I know you're not an expert.
That's above my pay grade. Yeah.
Okay.
But there are treatments, and there's definitely lower rates of treatment in the places where it's criminalized.
Great. If you know that answer to that clinical question, put it in the comments.
Sure. A couple other studies. One, a nice one of machine learning versus standard prediction rules for predicting hospital readmissions, which there's a lot of potential money and patient benefit behind, and found that machine learning did improve over standard scores a bit. Not a huge amount, but a little bit.
And that's the second time we've mentioned machine learning, and I should point out, which you know, but our viewers don't, that there's a call for papers on machine learning, that Fred Rivera, the editor-in-chief, and Steve Finn, the deputy editor, have expressed an interest in machine learning studies because it's such an area of rapid investigation. Doesn't mean that all of these papers are going to end up telling us things that we should use in practice, but it's a new technology, and we want to kind of understand how to do it properly, and hopefully we'll land some papers that end up telling us interesting things that we can use.
Yep, absolutely. And a lot of machine learning papers are also natural fits for JAMA Network Open because they cross disciplines and specialties quite a bit. Like this, a lot of them are too clinical for health informatics journals, but too technical for a lot of specialty journals. And also, just a lot of policy papers have a hard time finding a good journal, as I found after I did my health policy fellowship.
Got it.
Last one, prevalence of hypertension treatment and BP targets in Canada with the 2017 ACC and AHA blood pressure guidelines, which I believe revised down the blood pressure target for most patients because of SPRINT, because of the benefits found there. And basically, not surprisingly, they found that if you applied those new guidelines in Canada, the prevalence of high blood pressure would basically double, which, on the plus side would mean more people could be identified who could potentially get treatment or exercise, eat more healthfully, and do better. On the other side, medicalizes a lot of people who are living their lives without anything having changed for them, potentially subjecting them to harms from blood pressure medications, increased costs, et cetera. If they smoke and their blood pressure is 144, it might be a big problem for them.
Right, and I rarely say this, but that's not new, but it is important.
Right.
Because we've published in the JAMA network, I believe in JAMA, a similar paper for the United States, and I think a research letter around the same effect in India. Of course, when you lower blood pressure thresholds, many more people are going to be eligible for that label. And my friend and former mentor, Robbie Aronowitz, has talked about kind of this pre-disease stage, like that, we talk about pre-hypertension, pre-diabetes, and in a way that kind of converts this notion of risk or at risk or something future that may happen into a disease itself, so that it becomes indistinguishable, people who are kind of on the runway to developing a disease from the people who have the disease. They're labeled the same. or they're treated the same, and it is a real issue. It's certainly a boon to the pharmaceutical industry. And I should say about Sprint, though, that was not industry funded. That was NHLBI funded. And going back, one of the reasons there are so many secondary analysis of Sprint is because the investigators and the NHLBI made the provision that that data set should be free and available. So in the interest of openness and transparency, if you may remember, the NEJM had a contest for people that take the entire data set and present new reports and new projects. And that was awesome in 2016. I think the winner went to Israel, who went to an investigator in Israel who developed this kind of EHR interface with the data set to use the Sprint data to help predict patients who needed antihypertensives. In any event, blood pressure continues to be hugely important in our clinical practices, and so this study from Canada tells us the same thing in Canada as we know from US, India, and elsewhere.
Yeah, and also one of the studies in JAMA Network Open about Nepal a few months ago.
There you go.
Yeah.
Maybe that's maybe I'm confusing India and Nepal, which would be a bad thing for me to do.
Right. All right. Well, thank you for joining us. As always, please follow us on your various social media, Twitter, Facebook, LinkedIn at JAMA Network Open.
Subscribe to the Editor's Summary podcast on whatever platform you listen to your podcasts on. And remember, if you or your loved ones or colleagues speak Spanish or English, our titles and key points are now translated into those two languages.
And Mandarin.
And yes, and Mandarin. Forgive me.
It's all right. Well, thanks for joining. Take care.
Take care. See you next week.